some problem about the last lecture. I'll tell you when I come to the objectives. It's not going down this window. How can I send it down? It's not minimizing. Should minimize. Okay, it's coming again. Any suggestion?
The screen is clear to us.
The
We
small,
can see the objectives.
the small screen at the bottom, it will remain. It's
We
not
can
going
see
to
it.
minimize.
Just you who can see it.
Okay. Anyway, let's try to. Okay, the objectives, you can see the list. It's no need to go through, except that at the last, you can see the epidemiology, risk factors, and proteinuria. Actually, I was given this lecture, Dr. Irfan has to go in emergency on vacation. So when I looked at the lecture, I said it's too much. And he said, okay, last year or before that, that lecture was presented and they have made some questions for the bank. So it's better that you give them as an additional resource file. My lecture is almost 90% I've taken from that, and also Robbins, of course. Mainly I take Robbins and a video. And this thing I have not. The proteinuria portion is in the old lecture. So please be careful. If there's a question from proteinuria, then good students have to read the additional resources. So it was too much, I think, that to go through all these big lecture. So we start after the objectives. We see that the clinical manifestations of renal diseases are many. We all know about the two syndromes, the nephrotic syndrome and the nephritic syndrome. I have to switch off this. The nephrotic syndrome and the nephritic syndrome, and asymptomatic patients, they have just hematuria or little bit albuminuria in some conditions, which are detected by some other methods. Suppose he comes for some other problem and they find that patient has hematuria or proteinuria. And now these green highlights I've done today just now, these are the questions which came into my mind I have to submit to the bank. So I may ask you a question that what are the diseases that can cause asymptomatic clinical or subclinical manifestation of renal disease? So these are the two things which are important, that these two diseases can cause renal problems, but they are asymptomatic. So be careful about that. Then rapidly progressive glomerulonephritis is the very serious condition, and the renal function deteriorates in few days and weeks, and the patient goes into the, I'm sorry, it cannot go, what to do? This small window of team is all the time, it's not minimizing. So rapid progressive glomerulonephritis, acute renal injury is again acute condition, abrupt onset of hematuria, the increase in serum creatinine, oliguria, and urea can occur. And then chronic disease and the end stage renal disease. These are the different manifestations of the renal disease. But we have to see the main syndromes, nephrotic syndrome and the nephritic syndrome. These are very, very important. And I put the green highlight here because I may make some clinical scenarios from these, and then you can answer them. So be careful. These are very important. In nephrotic syndrome, there's massive proteinuria. They call it nephrotic range proteinuria, which should be at least 3.5 grams, should be more than 3.5 grams per day. Patient, after this so much loss of protein from the urine, patient develops hypoalbuminemia, generalized edema, hyperlipidemia, and lipiduria. This is what happens in the nephrotic syndrome. These are the main features. There are many other features also. In nephritic syndrome, the main feature is hematuria, mild proteinuria, hypoalbuminemia, hypertension, decrease in the urine output due to decreased GFR, creatinine is high, blood urea nitrogen is high. Patient may develop edema at a later stage. Edema is not a prominent feature of nephrotic syndrome. So nephrotic syndrome is our main target in the clinical features. And these are the 4 diseases that are the primary renal diseases that can cause nephrotic syndrome. These 2 are most common. Focal segmental glomerulonephritis is common in the adults, and minimal change disease is common in the children. And these are the 2 most important ones that can cause nephrotic syndrome. In the secondary or systemic diseases, we know about our case of diabetes mellitus can cause nephrotic syndrome. And these are the clinical pictures of nephrotic syndrome. Patient may have this facial puffiness, ascites, and pitting edema. See, this is the edema. We press on it, and there'll be pit formed because the fluid is displaced, and this is the pitting edema. These are the clinical features of nephrotic syndrome. How the pathophysiology works in nephrotic syndrome, how the edema occurs, how these all occurs, that when there's a lot of structural and physiochemical alteration, there's a lot of loss of protein, heavy proteinuria. That will lead to decrease in the serum albumin, hypoalbuminemia. You know, albumin is a molecule which exerts the colloid osmotic pressure. It tries to keep the fluid and electrolytes inside the blood vessels. That is colloid osmotic pressure. So when albumin is less, that will decrease the fluid in the vascular area, and there'll be plasma volume will decrease. When plasma volume is decreased, the GFR is decreased, and a reaction occurs in the body that when the GFR is low, the angiotensin, renin, angiotensin, aldosterone axis starts working. It becomes increased, the aldosterone increase, tries to retain some water and sodium, and more edema will occur. So edema is occurring from both sides. There's decrease in the volume and also because of the aldosterone. So there is edema. When it is severe, we call it anasarca. Anasarca means there's severe edema. Why this hyperlipidemia occurs? This is not so clear, but they say that when albumin is low, the liver tries to work and make more proteins. In making that compensatory synthesis of more proteins, it makes albumin, cannot make because it's a small molecule, is being leaking from the kidney. Then the other proteins are also made in greater quantity, like the lipoproteins, and they can lead to hyperlipidemia. And then when this is hyperlipidemia, it will also leak into the glomerular from the kidney to cause lipid urea. So this is the pathophysiology of nephrotic syndrome. Any questions? Clear? Okay. So nephrotic syndrome is slightly different. It is an acute condition caused by inflammatory lesions in the glomeruli. You see a lot of proliferation of the glomerular cells and infiltration by the leukocyte. That means it is inflammatory. The 2 causes can be divided into primary and secondary. The primary is post-infectious glomerulonephritis after streptococcus and crescentic glomerulonephritis. The secondary is systemic lupus erythematosus. What happens in nephrotic syndrome is that whenever there's injury to the blood vessel, blood will go into the urine. And because of that, there are changes in the hemodynamics. There will be changes in the pressures, etc. And GFR will become low. And then the body tries to retain the fluid, but it cannot. There'll be decrease in the urine, oliguria, and azotemia. You know what is azotemia? I left it in the first slide. Anyone can tell me what is azotemia? Understand? Anyone? I can see you. What is azotemia? Are you there, Noora? Okay, azotemia is increase in the blood urea nitrogen and serum creatinine. That is the term used when only these 2 things are increased. And uremia, we all know, is when there is azotemia plus clinical features. So this is the main difference I've given in the second slide, third slide, I think, the clinical features. What is the difference between? This is at the top bottom, you see difference between azotemia and uremia. These are clinical. Azotemia, when only the urea is increased and creatinine is increased. And uremia means when they are increased plus clinical features. That is the difference between the two. So please note it. I will put a question on it then. Then hypertension occurs in nephritic syndrome due to fluid retention and renin release from the ischemic kidney. The kidney is getting less blood because of all these hemodynamic changes. Causes, we all know, we have done in the opening session, everyone did this pre-renal, renal, and post-renal hypothesis. Coming to the histology, this glomerulus, again, the last case, most of the students, mashallah, they presented all these kidney structures, etc. Here you can see that it is an anastomosic network of capillaries. Histologically, it's difficult to identify, it's difficult. So we make diagrams and explain to the students. So in this diagram, you can see the parietal cells, this visceral layer of podocytes. They are called podocytes because of the food processes. Then these are the endothelial cells, the afferent arterioles. The basement membrane is again important. You see this basement membrane? We may ask you the question, what are the components or the constituents of the basement membrane? And finally, the mesangial cells, the dark gray colors, mesangial cells. This table was taken from the Robbins, and this is a list of the primary glomerular diseases and secondary glomerular diseases. Now coming to the important thing which needs explanation. I'm again trying to. Oh, so the glomerulus gets injured by two methods, immune methods, immunity mediated and non-immune mediated. You know about the immunity, it is antibody mediated and cell mediated. In the kidney, the cell mediated is very rare. Cell mediated injury is very rare. And it is in the experimental animals only. So mainly it is the antibody mediated immunity which causes damage to the renal kidney, the glomerular cells. It is of two types. When the antibodies, the immune molecules, immunoglobulins, they go and attach inside to the glomerular molecules, or they're already circulating complexes, and then they go and deposit in the glomerulus. We'll see these pictures now. Now they can see you here. These are just the antibodies. These are just the antibodies. They will go and they will bind to the molecules of the glomerulus. There's inside to binding. In this example, they are binding to the antigens on the podocytes. You know the podocytes, they have these antigens, and the antibodies, they go and join, attach there. So inside to binding. And in this case, you can see the basement membrane, antiglomerular basement membrane antibodies, they go and attach to the molecule, the antigen in the basement membrane. If we look at the complexes, which are already antigen antibody complexes, they are already bind together. So they just go and deposit. They deposit at different places in the glomerulus. Some deposit in the subepithelial area, some deposit in the subendothelial area. This is subendothelial deposit, this is subepithelial. Some go and deposit in the mesangial area. So we have to see why they go and deposit at specific places. Then is the, depending on this structure, the deposition, they are just complexes and deposits. We look at the immunofluorescence microscope, we see this granular. So this you can see the pathologists, when they report, they look at these slides under the special microscope called fluorescence microscope. They found granularity. So these are granular in pairs because they are bumpy. They are lumpy, bumpy. While the antibodies which they deposit in the basement membrane, they are without any complex. They are straight and without any bumps. They are linear. So there is linear immunofluorescence like this picture. More detail about these circulating immune complexes. What type of antigens are present in these complexes? Most important, of course, we know is the endogenous antigen is the systemic lupus erythematosus antigen from SLE. So this is always a problem in many organs. The exogenous antigen, this is again important. It is given in your Robin's PDF. I've sent you the 8 pages PDF. Which virus is the antigen in this case? In the circulating immune complexes, the virus involved is hepatitis virus. Hepatitis B virus is the virus which gets. So these are the questions I can put in the bank. The bacteria which is important here is the streptococcus. These antigens of the streptococcus, they get deposited in the immune complexes. The parasite important is the malarial parasite. Malarial falciparum parasite can deposit. They can attach with the complex and they deposit in the basement membrane. And the spirochete involved is the syphilis spirochete. Treponema pallidum spirochete is the antigen in this complex that can come and deposit in the glomerular membrane. But many times we don't know what antigen is there. So these complexes, when they reach this area in the glomerulus, in the basement membrane, in the porous between the porocytes, subepithelial and subendothelial area in the mesenterium, they will cause injury by activation of the complement system and by recruiting the leukocytes. So inflammation occurs by recruiting or activation of the complements. I hope you know what is complement. Let me hear. Anyone can tell me what is complement? Are you there? Anyone? What is a complement? Okay, what is a leukocyte? Who can tell me what is a leukocyte?
White
Immune
blood
cells.
cell.
In Mashallah. Faris, yes. Leukocyte is a white cell. Okay, leuco is white cell. And complement is a system. You know the coagulation system in the body circulating inactively. Then when there's bleeding, they get activated. So complement is also a system circulating in the plasma. They are in inactive form, but whenever there's inflammation, antigen antibody reaction, they become activated and help the WBC to kill the bacteria and do the inflammation. So complement is an important part in the immunity and inflammation system. Now we see this, if the complexes are large in size and they have a cation, they have a 3 positive or more positive ions, then they will deposit in the subendothelium. They will be, because they are large in size, they will not cross the basement membrane. They will remain here and more inflammation is produced. If they are small in size and the positive charge is less on them, they can cross the basement membrane and they go to the subepithelial surface. So they are on this side. And the molecules which are intermediate in size, they go to the mesenterium. This is important, again, a question which can be asked in your exam. Why a complex gets deposited in the subendothelial? Because of the molecular size and the electric charge on them. Looking at the in situ binding of the antibodies, the in situ binding occurs at 2 places: the intrinsic molecules of the glomerulus and extrinsic planted molecules. Intrinsic means they are the actual antigens of the basement membrane. The podocytes are the actual part of the basement membrane of the glomerulus, and similarly, the GBM, the glomerular basement membrane, is also actual intrinsic part. But some antigens are planted, they are coming from outside, like microbes. They have just the antigen, they are in the circulation, they come in the glomerulus and settle there. And then antibodies, the antibodies will come and attack them. So these are the planted molecules. The example of the intrinsic are two podocyte. You see this picture, podocytes are the intrinsic molecules, and the glomerular basement membrane is the intrinsic part, and the antibodies, they act on it. And the example of planted is microbes. This is Streptococcus group A. Endogenous planted molecule example again is DNA or nucleosomal complex after apoptosis. And endogenous, another example of endogenous is the immunoglobulin G, which deposits in the mesenterium. Here I must give you the example of a very important disease. These two important diseases, one is when the antigens, they attach to the podocytes, we call it, the disease is called Hayman nephritis, and the antigen is called Miguelin. The Miguelin antigen is present on the podocytes, and there are antibodies formed against this antigen, and that is how the podocytes are attacked. While the glomerular basement membrane is attacked by the antigen and by the antibodies in the disease called good pasture disease. In the good pasture disease, there are anti-GBM antibodies. These are autoantibodies. They cause severe form of rapidly progressive glomerulonephritis. So this is, if I don't know, in the second year you did this good pasture syndrome. This is a syndrome in which these antibodies, they attack the lung and the kidney. So the two organs are affected. So we call it good pasture syndrome. And there's a good pasture triad. Clinically, you see good pasture triad when you see the pulmonary hemorrhages, rapidly progressive glomerulonephritis, and anti-glomerular basement membrane antibodies. So this is a triad which occurs in this disease. Is it clear? Okay, so the
Yes.
same diagram, okay, mashallah, thanks God. I thought you have gone for tea. So in this, the same diagram, this is the diagram taken from the old lecture. This is the old edition pictures. You see these complexes here under the endothelium. The complexes form outside and then they deposit here. And then subepithelial deposit between the podocytes. The basement membrane is all right. But when we look at the antigens, antibodies, this is the anti-GBM antibody, which is forming smooth, continuous, linear form. There's no complexes, just a smooth lining. While in the antibody against the podocytes, they are forming small aggregates. So these forming granular form, and this is forming the linear form. Here you can see how it starts. The disease starts with this picture that the B lymphocytes, they are converted into plasma cells, which secrete the antibodies. These free antibodies, they combine with the antigens. They can form complexes and reach the kidney, and they try to attach. They take the help of complement. Their complement are these triangle, red triangle. They're the small molecules. And this is the WBC, the neutrophil, with this FC receptor. And this is how they produce the inflammation and vasculitis. This is how the inflammation is produced after the activation of neutrophil, which secretes all these lysosomal enzymes. That was the immune type of injury to the glomerulus. Now, the non-immune type is divided into three. Again, the ischemic causes are the ischemic and toxic causes are the drugs like non-steroidal anti-inflammatory drugs, chemotherapeutic agents, anti-cancer drugs, toxins like heavy metals, pesticides, and ischemia due to renal artery stenosis. These are the example of non-immune mediated injury to the glomerulus. The metabolic causes, we know about diabetes, which is our case, and then hyperlipidemia, amyloidosis, and gout are the metabolic causes of non-immune mediated injury to the glomerulus. Finally, the genetic type. It's a special disease called dense deposit disease. Dense deposit disease is a disease in which there's activation of complement pathway. Again, I must tell you that the coagulation, it activates by intrinsic pathway and extrinsic pathway. Similarly, the complement activates by two pathways. One is the classical pathway, The second is the alternative pathway. So there are two pathways by which the complement get activated and takes part in the inflammation. So in this disease, this activation occurs without regulation. This can occur in some genetic diseases. This is a genetic disease. Sometimes it can occur by acquired method by autoantibodies. So there is activation of complement system through the alternative pathway. And after the activation, there's uncontrolled activation. There's deposition of the complement C3. We know there are 13 factors in the coagulation system. In the complement system, there are 9 factors. So C3 is also one of the important one. So this gets deposited in the glomerulus and there's inflammation. So glomerular nephritis occurs in this, and then we call it, disease is called dense deposit disease because this appears as a very dense deposit on the electron microscopy. Again, this is an important table. Of course, we cannot do everything in one lecture. These are many lectures. So, and I hope I will not make any questions from this, don't worry. So we come to the next slide. We know that glomerular nephritis is the important target of today's lecture after diabetes mellitus and lymphatic nephropathy. Again, I must remind that minimal change and focal segmental glomerular sclerosis, these are the two important causes of nephrotic syndrome, which cause maximum proteinuria. So in that previous lecture, there was a lot of detail about proteinuria, what level is called micro, what is called normal, etc., etc. So I've left it. So you can just go through 4 or 5 slides from the old lecture, please. So here I was thinking of making a scenario. Now remember, this is a disease, minimal change is a disease of children, and focal segmental is a disease of adults in the beginning. So if I make a scenario that an adult came with nephrotic syndrome, so which is the most likely? So you have to answer this one. I'm giving you the hint that this can come in the quiz. I'll make it, but it's all the coordinators can select it or not. But this, I was revising, this question came to me, that when an adult comes with nephrotic syndrome and all the other features of the kidney disease, and we write in the options minimal change, although this is more common and more important in the children, it's less important in the adults. So this will be the answer. Then the fourth in this list is the diabetic nephropathy. So we cannot do all these. We'll just quickly go through the minimal change and then we'll go to diabetes. The minimal change disease is a relatively benign disorder in the children, most commonly in the age 1 to 7 years. And it's the most frequent cause of nephrotic syndrome. On the light microscopy, the glomera are completely normal. That is why it's called minimal change. You don't see anything on the light microscopy or immunofluorescence, but on the electron microscopy, what you find effacement, loss of food processes. You see, this is normal at the top. You see, these podocytes have the food processes. They are very important. If they are lost due to some reason, there's effacement of the, and then all the protein can pass. So the holes, the fenestrated holes in the capillaries are open now, and a lot of protein is lost. So this, on electron microscopy only, you can see the diffuse effacement or loss of podocyte food processes. So these are the green highlights. You can see that I can make questions. Which one is the most frequent cause of nephrotic syndrome? It is the minimal change disease. What happens in it? There's loss of podocyte food processes. Now coming to the kidney now, the diabetic nephropathy, renal pathology part 2. Definition, of course, we can quickly go through. There is a microvascular complication characterized by 3 features. This is a good MEQ question. This I've taken, the whole Robbins has given only just one paragraph of diabetic nephropathy. So I've condensed it. That is the leading cause of end-stage renal disease. It's the earliest manifestation is albuminuria. In the beginning, there is albuminuria, but not so significant, but it can point that patient is starting to have the damage to the kidney. 80% of type 1 will develop nephropathy in 10 to 15 years, and After the diagnosis of nephropathy, within 20 years, they will have end-stage renal disease, which will require dialysis and renal transplantation. This was one of the graphs I've taken from the last lecture, showing that it's quite an important disease in our population. About 15,000 people, in 2012, that is 12 years back, they needed dialysis for kidney failure in the kingdom. Here also, pathogenesis is important, which I'll try to explain. Now, this is the pathogenesis of complications of diabetes, because you remember our this week's case, it was the main phenomenon was the complications. Okay, so I'll try to solve the problem of complications, how these complications occur, how the hyperglycemia will cause damage to the organs or kidney. It causes damage to the organs by three methods. First method is called advanced glycation age end products. We call it age. By age, they cause the damage. They cause the microangiopathies. This is normal process. The glycation is a normal process in which the metabolites of the glucose gets metabolized into many things like glycol and methylglycols and all these. They combine with the amino groups of different proteins inside the cells and outside the cells non-enzymatically to form advanced glycation end products. This is a normal process, but very minimal, very little happens, not too much. But when there's hyperglycemia, this will lead to excessive age formation, and excessive, it remains for a long time, as we see in the HbA1c case, which we come to know that after 3 months, this thing becomes positive or easily understandable. So this is normally happening, but in hyperglycemia, it is severe. Now, when the ages are formed, they produce damage by two methods. One receptor mediated, the other is non-receptor mediated. Here you can see the age is binding to the receptor of age. And this receptor is present in these 4 cells. 1, 2, 3, 4 cells have receptors for age. Macrophages, T lymphocytes, endothelial cells, and the vascular smooth muscle cells. So this is, again, you can see green highlight is an important question. And when there is antigen and the receptor and ligand, they meet, then this cell gets activated and produce all these effects. Most important effect for the kidney is production of TGF beta. Transformation growth factor beta is produced that will be responsible for deposition of excessive basement membrane material. TGF beta will produce excessive basement membrane material, and that is one of the important problem in the glomerular capillaries. This substance, the VEGF, vascular endothelial growth factor, is more important in the eyes. Retinopathy, the microangiopathy in the retina is because of this vascular endothelial growth factor. And all these reactive oxygen species, ROS, procoagulant activities increase, vascular smooth muscle cell proliferates, and deposition of matrix. All these changes occur when there is excessive age, which combines with the receptor on these cells. So finally, we get the microangiopathy and vessel injury. It can also combine without receptor. The age can combine with many molecules. They directly cross-link many proteins, extracellular matrix proteins, directly without the help of receptors. One example is the type 1 collagen in the large blood vessels. Type 1 collagen is present in the large blood vessels. When age, they combine with these collagen, type 1 collagen, the large blood vessel lose their elasticity. Normally they are elastic. The elasticity decreases and leads to predisposing them to more injury, more hypertension, etc. can occur when there's decreased elasticity of the large blood vessels. But if it combines with the type 4 collagen, which is present in the basement membrane, as in kidney basement membrane, globular basement membrane. So what will happen? The endothelial cell adhesion is decreased. The endothelial cell is sitting on the basement membrane, and that basement membrane glue becomes loose because of this, and then decrease in the adhesions will make more fluid to pass through that basement membrane. So the fluid loss is increased because of this reaction with the age. The final product is that there is a receptor mediated damage, and there's non-receptor receptor mediated damage. And these blue are the substances. These are the albumin molecules. These 4 blue oval structures that when this basement membrane is glycated, it attracts and attaches to these albumin molecules. So now their basement membrane will be thickened. And so thickening of the basement membrane, one of the cause of this thickening of the basement membrane is the deposition of albumin in the type 4 collagen. This is also a question. You can see the star I made today. The second pathway of damage, is activation of protein kinase C. This happens intracellularly. I thought some good student will say intracellular hyperglycemia. I got this point that hyperglycemia means increased glucose in the blood circulation. So it cannot be intracellular except in the RBC. So it is not a good term to use. Anyway, when there's excessive glucose in the cells, there's production of a molecule called diacylglycerol. DAG, not the dog. You'll remember it now, easy, that it is not a dog, it is a DAG. Diacylglycerol is the molecule which is responsible for activation of protein kinase C. When protein kinase C is activated, this will stimulate the vascular endothelium and production of all these same factors, and microangiopathy is produced. When there's excessive glucose inside the cells, a substance is abnormally produced or excessively produced called diacylglycerol, which activates this protein kinase C, which will stimulate this vascular endothelium and production of all these factors which are responsible for microangiopathy. The third pathway of pathogenesis is increased susceptibility to oxidative stress. When there's increase in the glucose inside the cells, a substance called sorbitol is converted into fructose. This happens by the help of this enzyme, aldose reductase, and it uses this very important molecule. NADPH is converted into NADP. This is like a currency. We know normally I speak of the currency. ATP is a currency. It is an energy currency used in different structures. So this is also currency. This is also an energy bond. NADPH is converted to NADP. It's like if ATP has a Saudi Riyal, this is like a dollar and a euro. So it's more important, but in less quantity, so it becomes more important. So this energy is utilized in conversion of this molecule. So when in the cell there's more glucose, it is using this important molecule, this method of energy. It is using more dollars. On the other side, within the body, we have a normal glutathione. Glutathione is a molecule which is an antioxidant. It is preventing oxidation stress. So it also requires these dollars. This also required NADPH conversion. So if the quantity of NADPH is less, then the quantity of the reduced glutathione will also be less. So body will not be able to fight the oxygen stress. So this is because of this pathway. Whenever there's more glucose, some of its substances, sorbitol is converted into fructose, but it is using an important molecule called NADPH. And this molecule is also important for the normal molecule, which is the normal antioxidant of the cytoplasm. When this molecule is less, then of course this will become also less, and the cell will become more susceptible to the oxidative stress. So this was the pathogenesis of the injury to the membrane or the complications of the diabetes, the complications of hyperglycemia. Morphology becomes easy because it's not more important for you, so I'll quickly go through. So there are three types of lesions in the kidney in diabetes: glomerular lesions, vascular lesions, and the interstitial lesions, tubulo-interstitial lesions. In the glomerulus, we have the capillary basement membrane changes. The capillary basement membrane becomes thickened. There's mesangium becomes sclerosed. There's deposition of PAS positive material in the mesangium. And finally, we'll come to the last one, is the diffuse glomerular sclerosis, when more than 50% of the glomeruli show sclerosis. I've left the number 3 because this is the most important, more classical, important indicator of diabetes. So we'll do it in more detail. Nodular glomerular sclerosis. It is also called Kimmelstein-Wilson nodule. These were two scientists. This is the German one. This is an English scientist. They describe this nodule. This is the hyaline, spherical, ovoid nodule in the matrix of the glomerulus. This is the nodular glomerular sclerosis, which is very specific for diagnostic for the diabetic nephropathy or glomerulopathy. There's excessive mesangial matrix deposition. We call it Kimmelstein-Wilson nodule. More about it, that it is laminated. PAS, I thought you'll know it, but I'll tell you because of the time is less. Per iodic acid shift, this is a special stain which stains carbohydrates and glucose type of thing. Per iodic acid shift is a special stain. So this molecule, this nodule is positive for PAS and is present at the periphery of the glomerulus, not in the center. So at the periphery of the glomerulus and in the mesangium, there are no cells in it. They are just acellular hyaline matrix core. And there are some blood vessels around it. See, there are some blood vessels around it. That is why it is also called intercapillary glomerular sclerosis. Intercapillary glomerular sclerosis, because it is between the capillaries. So it has different names: nodular glomerular sclerosis, KW kidney, and intercapillary glomerular sclerosis. Other lesions are again fancy names. You can see them thickening, a drop, like a drop falling from the capsule. They call it capsular drop. And some of the capillaries, they have a cap on them. They call it fibrin cap. So there are different structures that can, which is not so important for the undergraduates. I personally think kidney itself is so difficult for the reporting pathologist. It will be more difficult for the undergraduates. And in the vessels, these are important. It's very nicely shown here. There's hyaline arteriolosclerosis. Arterioles, the afferent arterioles and the efferent arterioles get hyalinized. So this is very clear, very nice picture of hyaline arteriolosclerosis. This also occurs in the kidney of diabetics. Finally, of course, the tubules becomes atrophic. They are very small, lumen, and you don't see any cells lining them. They look like blood vessels all naked. And then between them in the interstitium, we have inflammation, acute inflammation, chronic inflammation. All these dots, the blue dots, are the inflammatory cells. Papillary necrosis, you can see by gross examination. The papillae, we know about, you have told us in the previous case also, the renal papillae, they get necrosed or they may not get necrosed in the diabetic kidney. Then fibrosis of the interstitium and atrophy of the tubules. Classification of diabetic nephropathy is the same as the histology we just saw, but they're just given a special name to it. The class 1 is the glomerular basement membrane thickening is a class 1. It's all trying to make it difficult for everyone to remember 395 nanometers, etc. So just the same fancy thing to classify. I think these are important for the nephrologist, for the treating clinicians. that what is the diagnosis by the pathologist. Accordingly, they make the decision to treat. So class 1 is the GBM thickening. Class 2 is the mesangial expansion, which may be A and B, mild and severe. Third is the important one, which we have just done, the nodular sclerosis. And 4 is the global glomerular sclerosis. If they have more than 50%, we call it class 4. So this is just a same morphological types. They have made it a classification. Just like a tumor, the tumors, we do the grading and staging of the tumors, cancers. So similar is here. So this is a classification on the basis of microscopy. And staging is on the basis of clinical features and radiology and other tests. It's just like the tumor. So now the staging, in the stage 1, 2, 3, they are just the beginning stages. In the first, they're just hyperfiltration. We can just check how much is the daily output of the urine. Then they come to know about the glomerular lesion. If they are suspecting, they took a biopsy and they find just a lesion, but no obvious clinical evidence of the disease. Then stage 3, it's about to start. Incipient nephropathy, only microalbuminuria is there. So this is just a start. The actual stage 4 is the overt diabetic nephropathy. When you see these features, then we can call it stage 4 is the cause. Then we can definitely say this because of the diabetes. When the proteinuria is greater than 500 milligram per day and albumin is greater than 200, creatine clearance is less than 70. Only this is the stage when we confirm, but it's too late. After a few years, the patient will go into the end stage renal disease. So this was the diabetic nephropathy stages. There are 5 stages and 4 classes. That was the end of the lecture. Alhamdulillah. I believe that the lecture should be short and so that you can absorb it. I was thinking of an example of you are a jug and you are cattle and you are trying to fill your knowledge into small cups. You are small cups. So we cannot overflow. You just get tired, of course. So these are the pages I've given to you as a resource to Yusuf, and he must have shared with you. And this is a very good video, a YouTube channel called I Love Pathology. He's an Indian gentleman, doctor, very nicely explained. All these screenshots I've taken from this video. And there's another one, there are 2 good videos on YouTube by this pathologist. And this is the same lecture, but of course, everyone, when they try to deliver lecture, they have to do it according to their own. It's very difficult to deliver lecture prepared by someone else. So I made my own lecture. Most of the material from this is in my lecture, except especially the classification of proteinuria. You'll see that it's very complex. I did not understand myself. How could I explain it to you? Okay, thank you. Any questions? You can, of course, message me on my WhatsApp. No one. Thank you very much. Any questions now?
Thank you, Doctor.
Thank you, Faris. Masalam.